Assalamu alaikum. Today we are discussing the partial nephrectomy in a renal tumor. Here you can see that there is a mass which is labeled as Bosniak 4 cyst in the right kidney lower pole. It is around 3 to 3.5 centimeter localized disease. So we decided to perform a laparoscopic partial nephrectomy. We have mobilized the colon. Now we are mobilizing the lower pole of the kidney. I have included this step just because I wanted to show two things. Number one, we have to look for the ureter and try to save it, not to injure it. Here you can see that the ureter is having a nice peristalsis. Number one. Number two, mobilization of the lower pole towards the pedicle is of extreme importance because as you know that we'll be clamping the pedicle. Good dissection of the pedicle is necessary, and to identify that pedicle and dissect it, it is important to mobilize the lower pole. As colon is already mobilized, duodenum is mobilized, the liver has been retracted, and dissecting along the lateral aspect of the inferior vena cava, we have gone to dissect and see the renal vein. So further dissecting and cleaning the renal vein now. On the CT, we have seen that the artery is located just posterior to the vein along its inferior border. So we consider ourselves to be lucky in that at least the artery is in the usual location. So we are dissecting the artery now, but this small vein, which is draining into the renal vein, a very small one, is very worrisome, because if it gets injured, there will be a lot of bleeding and the procedure will be compromised. Here you can very nicely see the artery. Now we dissect this vein, this one, yes. So I can't even clip it. I can't cut it with and coagulate it with the ligashore. The only thing would be to sew it or stitch it with the proline, which again is a cumbersome thing. So we are trying to stay away from that vein, not open it, and also dissect the artery nicely in order that a bulldog clamp can be applied. So we dissect between the artery and the vein to create a space which has now been created. Some bit of tissue that needs to be removed because if the bulldog clamp is catching this tissue as well, the artery may not be completely closed, and then there will be bleeding and the procedure's quality will be compromised. Again, this tissue has been released. So we have dissected between the vein and the artery, but the problem is that the vein is not completely dissected, and we have placed the normal bulldog clamps with the silk so that we do not lose it in the abdominal cavity. And then we place 3 sutures, one Vicryl 20 and 2 Vicryl 1, and we place them well attached to the anterior abdominal wall, so that once we clamp the artery, we do not lose time looking for the sutures and getting them into the peritoneal cavity and all that. Now all the homework is complete, so we are cleaning around the tumor to know where the base is. I'm not removing the fat and the garrota which is overlying the tumor or covering it. There are two reasons for that. Number one, we need to keep it on the tumor so that we know by microscopy whether there is any involvement of this fat or not, to know the invasion. This is reason number one. The reason number two is as we cannot grab and pull the tumor directly for the risk of rupture, we can very easily grab this fat and play around with the tumor easily. So these are the two reasons, and it will be obvious once we start dissecting, because we all know that dissection is all about traction and retraction. So we draw a line of cleavage on the normal renal parenchyma around the tumor, just to know that we will be cutting this area. Yes. So this is now complete, and we are going to apply the bulldog clamp, which is you can see that applied very well, and we see that there is no patency, the vein is not distending. The problem that occurred here is that I could not apply the bulldog on the vein completely because of risk of piercing the vein with the tip of the bulldog. So we decided, as the color of the kidney has already changed, so we decided just to apply the venous clamp for as much as we could. So there will be a little bit of retrograde bleed, but there will be no arterial bleed, so we'll be able to work. So now that we are seeing here is the retrograde blood which is collected in the kidney, but as we dissect the tumor, the kidney is getting emptied of blood, and then this bleeding will stop. So after creating this cleavage line, we are placing the suction at an area where it is providing a traction on the normal tissue, normal kidney, as well as it is cleaning the area as well. So you can see that my left hand instrument is grabbing the fat over the tumor and is pulling away. So, and the right hand is cutting the tumor. So the suction is placed at an area where it is also providing a counter traction. So that dissection has become easier with this technique. So always try to leave fat over the tumor. And we have dissected deep enough, and the cyst has not opened, and that was the aim. Here we can see that the lower pole calyx may have opened. Yes. So the tumor has been separated. Instead of placing the tumor in the bag for retrieval, we have placed it along the lateral aspect of the lower pole, because the ischemia time is really important. Since we are saving the kidney, so we are saving it in a true sense, instead of wasting time. So once we close this this rent and we declamp the kidney, we will place this tumor specimen into a glove bag. Economy plays an important role in laparoscopy. We are using Vicryl 2.0 here, and also applying the Hem-o-lok clips to make it tight. Otherwise, we could have used a V-lock suture or Stratafex for that matter by Ethicon, which does not require these Hem-o-lok clips. But those sutures have some disadvantages. They are monofilament and difficult to handle. There are also chances of breakage because they are monofilament. And number third, the last but not the least, is the price. However, I have been given a sample. It was too generous by the Ethicon. They have provided me a sample with the Stratafix, but that suture was 20, and its length was 30 centimeter. So that suture sample needs to be used somewhere else. Like, for example, I have a patient on list for vesicovaginal fistula repair, so I prefer to use it there instead of repairing this small defect. So we apply Surgicel on the raw surface. Number one, it is covering the raw surface. Number two, it is also hemostatic. So a little bit of ooze coming from the cortex will hopefully be stopped by this Surgicel. We did not close the small rent in the calyx because it was too minor, and this suture will already cover that rent. Another layer of Vicryl 1, which is a little deeper than this Vicryl 20. It will provide a little more hemostasis. It will also cover the rent in the lower pole calyx. And another important thing is that it is also securing this Surgicel very tightly over this rent, so it will play a role of hemostatic suture as well. So these two layers are about to get completed. Hemolog clips are used to tighten the suture and keep them in place so that they do not get loose and do not lose all the purpose. Once the repair is complete, we first remove the venous clamp, and then we remove the arterial clamp. And then we look for the bleeding. There is no major bleeding, luckily. Of course, there is a little bit of ooze, and that will be controlled by this these sutures and the Surgicel. So we have removed one needle of Vicryl 20, and we have also removed the two bulldog clamps. And now in the third layer, we are covering the defect by repairing the gyrotous fascia so that all the layers are restored. So the gold standard according to European Association guidelines nowadays is to perform partial nephrectomy in this case. And that should be done by minimal invasive technique. If a robot is available, that is grade A recommendation. If no robot, then laparoscopic is the next. However, if the skill is not available laparoscopically, then open partial nephrectomy or nephron sparing surgery is better than performing a laparoscopic radical nephrectomy. So we cut these needles and also remove them. The specimen is placed in the glove bag and then removed through the enlargement in the incision for the camera port. The enlarged incision is around 2.5 to 3 centimeter. Thank you very much for watching. This is the specimen that has been removed.